And this is Colette Crane. She is one of the physician's assistants that works with the therapeutic team. They are the reason that we run as well as we do. They field so many things that we never even have to see or deal with. And we are so appreciative. And so Colette is going to talk about EUS and ERCP.
Yep.
Right, yep.
So just double click on this little buddy. Oh, great. Oh, there's someone who helps. Fabulous. Mm-hmm. Okay. Hi, my name's Colette Crane. I'm one of the physician assistants here. I work in particularly the inpatient GI setting, just on the therapeutic side. So between myself, you may have seen Caitlin sitting down there in front with me, and Katie, there are three of us. And essentially our role is to run around the hospital, see people that have anything GI therapeutic related, work them up, see what their symptoms are, and then see if they need a procedure from our team. We staff it with our providers, and then we get them teed up for procedure. So today, I'm going to talk to you about the pancreas. I'm going to kind of keep it simple, everything that the pancreas does, and then the complications of the pancreas, and then how we can treat it. I want to go over a little bit about the anatomy of the pancreas, its pathology, how it works, understand when we need to go in and do something, and then we'll talk a little bit about evolving techniques and tools that you guys as the nursing team end up using, which I'm not as versed with, obviously. It's pretty amazing what all of the nurses do for all of these endoscopic procedures. It's pretty amazing. A lot of these patients would end up being surgical candidates or having to go into surgery if we didn't have the ability to do this endoscopically. So it's pretty remarkable. So the pancreas, this little guy, this little S-shaped organ, it's a retroperitoneal abdominal organ. That means it sits way, way back. So it's at the level of like the kidneys. So a lot of times patients with any sort of pancreatic etiology will complain of, I don't know what it is, I'm just having severe back pain. Or I feel like I'm going to get a UTI like I usually do. That's kind of how far back it sits. The pancreas is a really cool organ because it does two things. It's an exocrine organ, meaning that it releases all of these pancreatic juices into a duct, but then it also releases a bunch of hormones into the bloodstream. Okay, so some of the enzymes you probably know about is lipase. That works with your bile from your gallbladder. That's going to break down your fats. Then you have proteases. Those are going to break down your proteins. Then you have your amylase, which is going to break down like your carbohydrates, and then just a little bit of bicarb to make sure it's not so acidic. The endocrine portion is going to be all your hormones that are released in the bloodstream. So that's going to be like your insulin, your glucagon, or your somatostatin, the thing that kind of calms everything down. So cool organ. All right, three things I want to talk to you about anatomy. First, in this first slide, I just want you to see that kind of where the pancreas is located. So it's sandwiched between the stomach and this first part. Does my arrow? Oh, I have to use this. Oh. What do I do? Press it up here? But then I like can't see. You just leaned over. Okay. So just appreciate the fact that it's sandwiched between the stomach and the small bowel. Okay. This picture here is the endoscopic procedures that we do. Here you can appreciate that the pancreas is behind everybody. So the scope is going to go down the throat into the stomach and then into this first part of the small bowel. Once you get to that point, then we can access whatever we need into the pancreas. Okay. So it's not a far traveling job. Next thing about the anatomy is I want to talk about the ducts. So this picture here makes up the ducts of the pancreas. That is 90% of all of our anatomy. Okay. There are congenital problems and other things that can happen in while you're being born that can mess up the ducts, but this is 90%. This is all you need to know for the talk that I'm going to talk about today. So there's a main duct. This is the guy that's able to release pancreatic juices from the tail all the way down to the small bowel. Okay, this is called the duct of Wirsung. It's the main pancreatic duct. And then the little nubbin duct here that's above it is called the duct of Santorini. This is the minor duct, and it releases pancreatic juices just from the head of the pancreas instead of the entirety of it. Okay, juices that release out of the top here, this is called the minor papilla. And then the juices that are released out of here is called the major papilla, or sometimes we call it the ampulla of Vater. This one is where we do all of our endoscopic procedures for the sake of this talk. And this is important to recognize because that duct comes down and meets with the bile duct, which is seen in green in this picture. And so bile and pancreatic juices meet each other. And this is where they're emptied into the small bowel. Okay, so here, those ducts we're going to use kind of for this talk today. Third thing about anatomy is just the blood flow. So you have your aorta and your portal vein. These are big blood suppliers. It splits off into the celiac artery, which is this little guy here that splits off into your gastroduodenal artery, which gives blood supply to the head of the pancreas and the uncinate. And then it splits off to the splenic artery, which is going to feed the body of the pancreas and the tail of the pancreas. This is important for procedures we start to talk about a little bit later on because often there is a risk of bleeding as we start poking around here, okay? So 3 things I want to talk about today: acute pancreatitis, chronic pancreatitis, pancreatic cancers and cysts, and then how we work them up, and then what we do endoscopically to treat them. So let's start with acute pancreatitis. What is acute pancreatitis? So something you did is going to acutely injure the pancreas. The next slide, I'll show you what those things are. But the pancreas is a very moody individual. You put something in your body, you drink a bunch of alcohol, you upset it. Now the cells of the pancreas and the duct of the pancreas get so angry that they start to get leaky with all of these enzymes that they typically redirect to the small bowel. Okay, you can imagine a bunch of enzymes outside of an organ or a duct is going to cause a lot of pain. Okay. And in order to say, hey, you have acute pancreatitis, you have to have 2 of these 3 things. Okay. So when you go to see a patient, either they're in severe epigastric pain and or a serum lipase of 3 times upper limit of normal, right? So that lipase should be going down into the small bowel to help you digest. But in this case, it's in the bloodstream, so it's leaked out. So it should be very, very high. Or you got a CT scan or imaging that shows a lot of inflammation in the pancreas. So 2 of those things. Here are some causes. 80% of acute pancreatitis is caused by alcohol. That's a lot. So when someone comes in with a acute cause of pancreatitis, the number 1 question you should be asking is, how much do you drink? Endoscopic procedures that we do can give you pancreatitis. Autoimmune problems, genetic problems. We usually see pancreatitis in people under the age of 21 for this. Anatomical variants of the duct. Remember, I told you what it should look like, but it can get messed up. Certain medications, cancer of the pancreas, oddly, a scorpion bite. Trauma, we've had a couple bulls hit someone in the left side of the abdomen. That'll really tick off the pancreas. Or idiopathic, we have absolutely no idea what's going on with you. Okay, so if you're diagnosed with pancreatitis, God help us all, hopefully it's short-lived, meaning that you get it, the pancreas got super inflamed and angry, I give you fluids, I give you pain meds, you're out the door. If you get a complication, 2 complications I'm going to talk to you about are these pseudocysts and these pancreatic duct leaks, it's a problem and we probably need to intervene. People who get acute pancreatitis, 20% of them are going to get one of these complications. And if you get a complication, your mortality rate is upwards of 20 to 30%. So it's important to intervene quickly, to recognize it, and to be at a facility that has the ability to intervene. First one let's talk about is pancreatic pseudocysts. So this is a CT. This is huge. If you can imagine this being the bottom of your abdomen here, liver up here, stomach up here. This is a collection that is taking up the majority of your abdomen here. This is a pancreatic pseudocyst. Okay, so you got acute pancreatitis, you leak some fluids, but instead of the body kind of healing itself, the body created a inflammatory cascade that pulled in water with it in order to create some sort of healing. But as an effect, you got this collection. Okay, and they can be big or small. This one is just, I'm exaggerating it for you. And the interesting thing about pancreatic pseudocysts is that they always make a wall around them. It's just the way that they act. So the body kind of panics with all of this fluid, and it's going to create a fibrous wall or a scarring down of this collection in an effort to try to heal it. Okay. And you can appreciate that in the white. That's the wall that's starting to form around it. And this is just kind of an anatomy piece of the wall being made. I'm going to talk about some cysts later on. So this is what is very unique about pancreatic pseudocysts. So when do you know to do something with these patients? It's all based on symptoms. Okay. Some pseudocysts will heal on their own. The body will do a good job. It'll wall it off. It'll start to reabsorb. But there are times when patients get very, very ill, either pain, nausea, vomiting, early satiety where you munch on a cracker and you just feel really, really full, or this collection starts to get infected. So we only intervene when you start to have those symptoms. Keep in mind that these collections have to create that wall for us to go poke them. And I have a couple other pictures that may be more helpful for you to see, but it must have that wall around them in order for us to all endoscopically intervene. Okay. Typically cysts greater than 5 to 6 centimeters are probably going to cause symptoms because it's right by that tummy and small bowel. But size alone does not determine whether or not we go in and poke this thing. So how do we poke it? We do it with what's called an endoscopic ultrasound, which is a scope that at the end of it has an ultrasound probe. Okay. And it is able to deploy a stent across the stomach wall into the collection to help the collection start to decompress. Okay. Picture here. This is the scope. This is not an ultrasound. But this is the stent that's going to be deployed across the stomach wall into the cyst. And there it is. And then this is a CT scan. So if you can appreciate, the stomach is up here. You deploy this weird looking, barbell kind of stent here. And then this is the collection all the way down in the pelvis. Consider the liver up here. So it's pretty huge. And so this stent is now going to allow all of this collection to start to drain through the stomach. And so the whole thing is going to start to decompress and go away. And that'll relieve symptoms quickly. Here's another picture. Here's an actual EUS picture. So this is what the docs and you guys as nurses will see. Stomach's over here. And then this is identifying the actual cyst. It's dark black. And then once you deploy that metal stent, brown murky gunk comes out. That's pretty pathognomonic for a pseudocyst. And then the picture on the right is looking you're in the stomach and you're looking at the stent. They happen to place another little plastic stent through that just to help overall with draining. Okay. These stents dwell for about 4 weeks. That's how long it takes for this thing to drain. And sometimes we have to go back in and manually start to clean out very, very large collections, okay? After about 3 to 4 weeks, we'll get a CT scan and start to see if that collection is starting to get smaller and smaller and smaller. And then we remove everything. And most patients go back to their normal life. Keep in mind, this is a big stent. So those arteries we talked about in the beginning, there is about a 10 to 15% chance of bleeding in deployment of these stents. And that is actually considered a moderate to high risk for this procedure. Okay, next complication of acute pancreatitis, we're going to talk about duct leaks. So you've gotten acute pancreatitis, bunch of garbage is leaked out, but now your pancreatitis was so severe that the pancreatic juices are now actually starting to leak outside the wrong way. So instead of going down this way into the small bowel, this is our scope here. Instead of going down the small bowel to help you digest, it's leaking out the back end. Remember, these are enzymes, so it's extremely painful. Pancreatic duct leaks are strongly correlated with disease severity, meaning the worse your pancreatitis is, the more likely you're going to have a pancreatic duct leak. And in acute pancreatitis, it typically happens in about 3 to 38% of patients. This can also happen in chronic pancreatitis, although the incidence of this happening is less known. So they kind of give you a range of about 10 to 20% where you get this leak. So you're gonna require intervention on these duct leaks if you have symptoms similar to our pseudocysts. So try to imagine all of those enzymes are leaking out the backside. So you're gonna get pancreatic ascites, meaning you're gonna kind of fill up with all of these juices. You're gonna start to have abdominal pain. Sometimes the body gets real ticked off that there's fluid within the abdomen. So it visualizes all of those juices up to the lung in an effort to find a way to get this stuff out of there. And then sometimes it just all gets infected. We treat this by doing an ERCP. So we haven't talked about this yet, but an ERCP stands for an endoscopic retrograde cholangiopancreatography. Big word for us going in backwards into the pancreas, hence the retrograde part. Cholangio stands for biliary tree, which we can go into too, or pancreatography, meaning we're going into the pancreas, but we're going the backwards way of the way the enzymes run. This is a great way for us to identify the duct and then use contrast dye to identify strictures, stones, and masses. So for a pancreatic duct leak, we're going to do an ERCP. So we're going to get down into that first part of the small bowel. And the goal here is to place a stent, a plastic stent. They're small. The whole goal of this is to divert those pancreatic juices the right direction and allow that end tail of the pancreas to heal. Stenting and ERCPing with pancreatic duct leaks has an 80% success rate. So this is kind of a sequence of an ERCP very quickly in 4 photos. Here's your major papilla. Remember, that's that major duct that combines with the bile duct. So I know I'm at that major papilla because I see bile coming out. So I know that if I can get in here and go that way, I'll be into the pancreas, okay? Then we get a wire in there, we shoot some contrast, and we identify the leak, which you can kind of see right there. After the procedure, this is a little plastic stent sticking out into the small bowel, okay, helping everything run the right direction. Yeah. That's a great question. Both. Oh, full, I'm sorry. So that's acute pancreatitis. Those are 2 big complications and then how we can treat them. So now I'll talk to you a little bit about chronic pancreatitis, and what we do for them. So chronic pancreatitis, as you can probably imagine, is acute pancreatitis, but it really never goes away, or it keeps coming back over and over again. It's repeated injury to the pancreas over time. It causes a progressive fibroinflammatory process. What does that mean? It just essentially means a bunch of scarring down and thickening of the tissue and ducts of the pancreas. The most common causes of chronic pancreatitis is tobacco use and ongoing alcohol use. I should probably also mention, so while you're scarring down the pancreas over time, you're going to start to lose that ability to release enzymes into ducts. And then you're also going to lose that ability to release hormones into the bloodstream. So you can kind of imagine where we're going with that, but it can be very detrimental. So 2 big things that we can take care of endoscopically for chronic pancreatitis are going to be ductal changes, meaning that this ongoing scarring down of the pancreas has now affected the duct of the pancreas, so much so that it has caused a stricture, meaning like a narrowing or kind of a beating of the duct. And then like we talked about earlier on acute pancreatitis, it can also cause a duct leak where it goes the other way. The other complication is stones. Stones primarily in the duct. And then I didn't put this in red, but this is another complication of chronic pancreatitis, which is ongoing pain that it's going to require opioids for the rest of your life, maldigestion, because you've destroyed a working portion of the pancreas. So you're eating and it's really not getting reabsorbed. And then diabetes, because you're starting to destroy that endocrine portion that releases the insulin. Endoscopically, not much we can do about that. So let's talk about ductal changes, these strictures. So in this picture here, you can kind of appreciate that the duct itself is not really nice and smooth. Hence, because it's been injured so many times, it kind of starts to scar down. Picture all the way on the left is the goal of what we're going to do here, which is to place a stent in here, similar to what we did for duct leaks. So we do this with an ERCP. Okay, so we go in there, we access the major papilla. We do a sphincterotomy, which I haven't talked about, but that is the opening up of that major papilla so we can get ourselves in there. And then we're going to place a stent. The difference here compared to what we were doing for duct leaks is that this is a prolonged approach. So this duct is messed up. So we're going to put a stent in it to help it relax a little bit. And then over 6 to 12 months, you're going to start to increase that stent so that you can start to get remodeling of that duct so that it's nice and normal. This approach gives pain relief to patients up to 85% of them. Some evolving techniques that we don't particularly use here, but some things that are kind of up and coming is putting in a fully covered metal stent. So far we've talked about these little nubbin stents that are tiny, but the idea is that maybe you could use a really big stent. See how big that is compared to this one? Put it into the pancreatic duct stent, leave it in for a couple months and be done. So that way the patient wouldn't have to come back for 12 months and keep upsizing it. The problem is these have horrible adverse events. These stents move, the big ones, and then they also block the bile duct because remember that can come right off of the pancreatic duct. So, but some emerging ideas. Here's the procedure in terms of a cholangiogram. So when we go in to do an ERCP, we're shooting a bunch of contrast into the duct. So here's a gallbladder, it fills up really nice. And then the gallbladder releases out of the common bile duct, and then it merges with the pancreatic duct. The pancreatic duct, this should be a nice smooth duct, just like this, but you can see these strictures and these intermittent narrowings. So we're identifying a stricture, and there's a really nice one too, okay? Here you can see the fibrosis and then stent placement. So 6 to 12 months, hopefully we can get that back and running. I already talked about that. Oh no, this is my calcifications. Okay, so now let's talk about stones with chronic pancreatitis. So when you have repeated injury of the pancreas, not only does it affect the duct, but it affects the enzymes that want to release out of it. So when all the enzymes go to get out of the pancreatic duct, if they aren't moving as quickly as they should, and they kind of start to slow down because of that stricture, you're going to start to get stasis of the secretions and essentially a protein plug. That protein plug over time will become a calcified stone in the duct, okay? You also can get stones in the parenchyma of the pancreas, meaning the tissue of the pancreas, for the same idea. Those cells are also trying to release a bunch of enzymes and hormones, but everything is slowed down when everything's so scarred down, so then you get stones. If you see any kind of stone on a CT scan, that is like hallmark chronic pancreatitis. You see these little stones sitting around in the pancreas, you know this patient has chronic pancreatitis. They've had repeated injury to their pancreas. Two different pictures. So keep in mind that if you have stones in the tissue of the pancreas, we can't do anything about that. I can't get there. I can't pick out all of those stones. So the only thing endoscopically that we're working on is stones that are in the duct. And we know when they're in the duct, when we see dilation upstream from the stone, if you can appreciate that. I mean, this is a whopping stone. but look at the duct is pretty big, that dark area. That duct's responding, it's freaking out, it can't get its enzymes out, so it's getting bigger and bigger in an effort to help itself. That we can work on. This, I don't know what's going on. There's stones freaking everywhere, right? I don't know what's in the duct. I don't know what's in the tissue. There's just a lot of them. All I really know at this point is that the patient has chronic pancreatitis, probably from smoking or drinking. And either I will be able to help them with an ERCP and stenting, or I'm not. And this is going to be lifelong chronic pain management and no alcohol, no smoking, not even for a birthday. Okay. So when I talk about stones, I'm talking about ductal stones because these are the ones we can go get, okay? And it all depends on size. So stones that are Inselsteins, tiny, less than 5 millimeters, we're gonna go get them with an ERCP. And I'll show you a picture of that. Kind of what we've been talking about. Get down to that major papilla, open it up with a sphincterotomy, dilate the duct, go in there, get some stones out, okay? Large stones, kind of like the one I just showed you, is going to require breaking them down into tiny pieces and then going in and getting them out. So small stones, we've been talking about ERCPs. Here's kind of a sequential process of it. One, find that major papilla. This one doesn't have the nice bile coming out of it, but identify it. Fillet that little sucker open so that we can get all of our scopes and wires in there. And then deploy a balloon starting at the tail of the pancreas all the way down, and you start sweeping out these little buddies, okay? A final cholangiogram or a contrast study will show that you've gotten majority of the stones out, okay? Now, if you continue to drink and smoke, this may continue to happen over and over again. But hopefully this is a one and done. Large stones over 5 millimeters are going to require a couple things. So right now, guidelines are showing that the first thing we should start with is S-wall. We have some studies here at UC Health that we're kind of trying to figure out what's the best move. But right now, if you got a big stone, we're going to try to break it up first. We do this with S-wall. It's called extracorporeal shockwave lithotripsy. Extracorporeal just means outside the body. So all we're doing is trying to break up the stones from outside the body. So the patient lays down, this little shockwave therapy targets the stone in the pancreatic duct, bang, bang, bang. Hopefully it breaks up. This is a before and after. These are really hard to kind of appreciate, but the darker area on the x-ray are stones. And then after S-wall or the shockwave therapy, you see a lot less of it, okay? People who receive S-wall achieve over 90% of fragmentation of these stones. So that's pretty darn good. And then after you fragment them with S-wall, you still have to go in and get them out. So by way of ERCP. So let's say either at your facility, you don't have S-wall to do the outside shockwave therapy, or let's say you did S-wall, but the stones didn't break up as much as you thought. Another option is to do pancreatoscopy. So this is an endoscopic procedure similar to an ERCP, but it's using a specific scope. This specific scope is able to not only look at the ductal mucosa, meaning the actual inside of the duct. That's not something we've done thus far. We can identify the stone and start shooting with some shockwave therapy, and then we can break it up into tiny little pieces. And again, just like the other one, we're going to have to do an ERCP to sweep everybody out. Success rate here on pancreatoscopy is just a little bit littler at about 88%. All right. Last but not least, I want to talk about pancreatic cancers and pancreatic cysts and what we do for them. So pancreatic cancers have a horrible mortality, morbidity rate. So it's important to get these sampled as quickly as possible. The most common pancreatic cancer is called pancreatic adenocarcinoma, and it makes up 85% of our cancers, our pancreatic cancers. Here's a CT scan. Pancreatic cancers are hard because they're not well defined on CT. So it's very hazy. I don't know what's going on, but it doesn't look right kind of thing. It's hazy. It's not well defined. It doesn't have a wall. Okay. Over here is going to be a cyst. A cyst, a little more well-defined, and it has an obstructive component, meaning you can see that upstream pancreatic ductal dilation. So cysts, it can be confusing. So we talked about pancreatic pseudocysts. Cysts are a group of cysts that are made from abnormal cells. We can't really pinpoint why or how, but the cells are not normal. And they create these cysts. All pancreatic cysts have a malignant potential, meaning that the cells are just not normal. So as they start to divide, they're not going to do normal things. So every one of the pancreatic cysts can become cancer. These two I've listed here are the highest rate of pancreatic cancer. Intraductal papillary mucinous neoplasms, these are cysts that release mucin, have the highest chance of becoming cancer, upwards to 38 to 85%. Mucinous cystic neoplasms, more commonly in women, their chance of malignancy is anywhere from 10 to 34%. So if you identify a cyst or you don't know what it is you're seeing, we need to sample it. Big table that I'm not going to go through, but this is a list of our pancreatic cysts. They all have different distinguishable features to them. They all have different malignant potential, and they're all just a little bit different. Okay. You can see up on top, pancreatic pseudocyst that we talked first has a 0% chance of malignancy. So that's the biggest difference. Keep in mind also with pancreatic cysts, they don't create the wall around them, similar to the pseudocysts that we saw. And sometimes you can appreciate that on CT. Regardless, these need to be sampled because of their risk. So how do we sample them? So similar to the way we got into a pancreatic pseudocyst by EUS, we're going to do that for sampling here. An EUS is minimally invasive. It uses high frequency ultrasound in order to sit on the edge of the stomach and view the pancreas in order to see how big everything is and if there's anything we can biopsy. EUS is really great because it also allows you to see surrounding features too, like lymph nodes, spleen, liver. EUS is superior to CT or MRI. So if you get a CT, something looks questionable, it's reasonable to move on to an EUS. There's a couple different ways we can sample these suckers. So we can do it with FNA, which is a fine needle aspirate. This is for solid and cystic tumors, solid like our actual pancreatic adenocarcinoma. And the nice thing about needle aspiration is you can take cells for cytology, fluid analysis, and DNA testing. And then some oncologists will want an FNB, which is a fine needle biopsy. It's just a bigger needle. But this allows us to get a core biopsy to send for immunochemistries, molecular testing, or any type of subtyping so that they can do direct therapy for these types of patients. Here's a picture. So ultrasound, right? Stomach over here, you're going to identify the cyst, which is this darker area here. Once you identify it, then you're going to inject one of whatever needle you're using, an FNA, FNB, in order to grab a sample. Okay. And then here's kind of an animated picture too of grabbing samples. And there's different needles you can use. Keep in mind the needle all the way to your left is an FNA, and then all the needles afterwards are FMBs. There's this evolving technique for tumors and for cysts, particularly mucinous cysts. Remember, those had like the 38% risk of malignancy, where we use an EUS scope and we're going to directly inject a chemotherapeutic agent into the cyst. The goal of this is to induce local destruction or cyst breakdown so that hopefully the cyst goes away or it reduces in size. To a point that if it were a tumor, it could be surgically removed. Okay. All right. Finishing up here. I know it's been a long day for you guys. So this is the last thing I want to talk about is pain management and what we can do for it in the endoscopic world. So as you can kind of imagine, in all of these things that happen to the pancreas, a lot of patients have pain. So our team can offer EUS guided celiac plexus blocks. We only use them for patients with chronic panc or pancreatic cancer. Okay. This is a minimally invasive procedure, just like all of our EUSs, that uses a local anesthetic, or you could even use a steroid. And you're going to bathe the nerves that shoot a message from the pancreas up to the brain that you are in pain. This is not permanent, but this allows for patients to decrease their opioid use and have less pain overall, a better quality of life. So what is an EUS celiac plexus block? So we talked about the blood flow to the pancreas, the celiac artery being the first little nubbin that came off of the aorta here. So that celiac artery is surrounded by nerves. Those nerves are a plexus that then innervate all of the abdominal organs. So, sorry, I keep touching that. So one of the celiac plexus that comes off of the artery is sending signals to the pancreas and to the stomach. Our goal here in this procedure is to bathe that plexus of nerves with an anesthetic to stop the pain. Celiac plexus blocks are pretty successful in pain. They work best with pancreatic cancer, and I don't really have a reason behind that, but they get the most pain relief with an EUS celiac plexus block. Obviously, you're shooting lidocaine or corticosteroids into your abdomen. So if it's picked up by the blood, you may have diarrhea or hypotension from that. Very mild adverse events. We're near an artery, a big artery. So obviously one of the risks of this procedure would be bleeding. Here it is again. So celiac artery, that's in red, comes off of the aorta like we're talking about. Celiac artery here comes off, right there to the aorta. We know around here somewhere is the plexus block. You don't see that in the ultrasound, but we know that if the artery is here and the nerves are in yellow, we know they're intimately that close to the artery. So take your EUS scope down, bathe that area with something to numb it up, and get the patient some pain relief. I'm just showing this picture here on the right because a lot of institutions don't offer EUS celiac plexus blocks, and so you may be familiar with percutaneous celiac plexus blocks where they can go through the back and inject with pain relief. This is preferred. It's less risky, but just kind of wanted to put this on your radar. Some patients may tell you that, or some institutions only do those. If you get pain relief from the lidocaine or the corticosteroid we put on there, we have something called a radiofrequency ablation. Lula talked a little bit about it for Barrett's. This is different, but it's still using that radiofrequency energy. And the goal here is to ablate that plexus of nerves. Again, it's not permanent, but it will give you a longer relief of pain if you got relief from the first one, from the celiac plexus block with lidocaine or steroids. Okay, it's superior to the other one. Okay, so that's everything. So we talked about endoscopically how you can intervene on acute pancreatitis, chronic pancreatitis, and tumors and/or cysts, and how we can do it endoscopically. That is everything. Thank you. Oh.
I just wanted to confirm, you were saying if the chemical like worked, then you would go into ablate it versus if it didn't work.
So if patients do not get relief with steroids or lidocaine in that area, we do not move on to a radiofrequency ablation. So kind of start out simple. If targeting that nerve made a difference for you, then heck, let's go burn it, kind of thing. Don't burn it first. Yeah. Yeah. We're always told to give lots of fluids to these patients. What do fluids do for them? Like, why is that helpful? For which one? For the. Yeah, great question. So when you